Hello, I'm Dr. John Cruz, and today I'm going to be talking about having a question and answer session. The launching pad for that is the video I put out this weekend, which is about whether stomach acidity, meals in particular, can affect medication drug levels. So I will start with a less than 3-minute recap of that and then be open for questions on that topic or other topic. I'm not sure how good connectivity is because I took a minute wouldn't let me go live to begin with. So we'll bear with whatever it is. So the recap is as simple as this. What you eat, if it's highly acidic, and that's usually orange juice, other citrus products, certain soft drinks, Coca-Cola, vitamin C can acidify the stomach. When the stomach is more acidic, that means weak bases, and both Ritalin and methylphenidate and many of our other drugs are weak bases. They are more highly ionized in a highly acidic environment. And when drugs are more highly ionized, they have more trouble passing across the cell membrane from the contents of the stomach into the bloodstream, or into the cell first and then bloodstream. So acidification can decrease absorption of certain drugs. And at the same time, when the urine is more acidified, because we're not as concerned there with crossing cell membranes because of how the kidney works, which I won't get into, it's a more ionized environment, that it's easier for a highly ionized drug to flow into the urine, which means it's a double whammy, that there's less absorption and there can be more rapid excretion. So one would think that there's a potential for decreasing blood levels as if you eat food or eat or drink with a high acid content. The real world experience, and some of the comments written into, so some people notice some of these effects, others don't. And part of why these effects aren't universal, even though these principles are universal, is that one, very little absorption actually happens in the stomach. The stomach's a tiny little sac. It's mostly acidifying, mushing things around, shaking them up and exposing them to high acid so they break down. And most of the absorption, some absorption happens there, but most of the absorption is in your meters and meters of small intestine. The surface area of the intestine's about the size of a very large living room. So massive surface area there. And the acidification, the acidity of the stomach has some impact on the very beginning parts of the small intestine, but as further along you go, the less impact it has. So that's one reason many people don't notice much effect. Reason number two is that many drugs, particularly our long-acting drugs, are either coated or locked in a matrix that dissolves slowly, so very little of it is broken into pieces small enough to be absorbed in the stomach. That's happening more in the small intestine. And third factor is that drug levels, even if absorption is affected somewhat, the level of the drug in your blood for most of our drugs is more strongly determined by metabolic activity of different liver enzymes chewing up the drug or not. So these factors can play a role. If you're sensitive to them, then you should separate meals by at least an hour from high acid foods. If you don't notice an issue, then I wouldn't worry about it too much. A few exceptions, Mydayis, some of the coatings in that drug, and there may well be others, but I know that specifically for Mydayis, some of the coatings are specifically pH dependent, so altering stomach acidity may have more impact on that. And that's about the summary, and I will launch into any questions anyone might have. I am not seeing anything written down yet. Okay. Hello, Mr. AKA. So Good question. So Mr. AKA asks, does the high dose of vitamin C stop further absorption of amphetamine in the GI tract, or does it prevent amphetamine from working even in the bloodstream? So when we take highly acid foods, that does change, and measurably can change the pH of your stomach by a unit or two. pH, again, is a logarithmic scale, so going from a 2 to a 3 or 3 to a 2 or a 2 to a 1 is a tenfold increase in available hydrogen ions or strength of the acid. Our blood is kept within a very narrow range of around close to 7.3. If your blood pH varies by more than a tenth or two of the pH unit, you are probably dead. So many chemical reactions, so many other necessary functions of the body absolutely require a fairly narrow range of your blood pH, and CSF, the fluid that's bathing the brain, is also similarly kept in a very narrow range. So taking in lots of stomach or acid into your stomach can change the acidity within your stomach, might even change the acidity of your urine, but actually tends to have very little impact on blood blood pH. And if blood pH does start to vary, I mean, actually, the biggest method for adjusting or quickly adjusting blood pH is by breathing. So the major component for determining acidity of the blood is carbon dioxide dissolved in the blood. And if you start hyperventilating and blowing it off, you are blowing off acid, you are making your blood more basic, but it's still within a fairly narrow range. So again, so it's actual absorption getting from the lumen, the inside of the stomach, through the cells in the walls of the stomach and mostly intestine. So again, the other thing is much more absorption takes place in the small intestine than does in the stomach itself. So there. So KLB Kate is asking the same thing. And again, I'm open to any questions on ADHD or mental health in general, or should you dump your boyfriend or not? Or, I'm being a little flippant there, and I know I have a wry sense of humor and may not express it, but open to other questions. So Mr. AKA says, explain the effect of fiber supplement on drug absorption. Does it cause a massive difference or minimal? So when I did the research looking for acid effects on specifically affecting stimulants, and there's a lot of websites out there that will caution against it. It's sort of a basic caution. I could not find a single study that actually said, here, let's take the Ritalin with a glass of orange juice and compare it to taking it with a glass of water on a different day. There is virtually no rigorous study on that. Now, there is a little more research on looking at urine acidification levels, and particularly the concern is it easier to detect essentially amphetamine or methamphetamine, or is the ratio of those skewed or altered? Methamphetamine breakdown product isn't amphetamine. So there's more than 100 articles on that. Again, virtually nothing on actually experimentally seeing, what percentage of people or what extent is affected. And there's a handful of studies looking at absorption rates, particularly of a fatty meal. So there's 3 or 4 studies in the stimulant ADHD medication realm. And there it suggests that having a large fatty meal slows down absorption and delays it. And in some cases, you may actually, some it's delayed, sometimes it's actually less is actually getting in, it's so delayed. I am not aware of any rigorous studies with fiber, specifically with ADHD medication stimulants or others. I would not expect for most people, most of the time, it to be affecting. So other factors, I mean, if the medication drug is binding to proteins before it can be absorbed, that's going to block absorption. The pH may affect it. Fiber is essentially working as something that isn't getting absorbed, that's passing through your whole digestive system and actually holding onto water, which is why it helps with constipation, and it can actually help with diarrhea. It can help both ways. But I don't know of much difference, again, in drug use. So Sirhat one, and if I'm mingling your names, I'm sorry, but I'm doing the best I know how with my Midwest English. So Sirhat's spending over $400 on Vyvanse every month for the brand version, but for the last couple months, he feels like it's not really working the same way it used to be before. Any suggestions? So I have had some patients successfully petition their insurance company if they can document that they had differential and particularly inferior responses to a generic than to a brand name with Concerta, with Vyvanse. One, the doctor has to be willing to put in the paperwork, and two, there's no requirement at any government level in the US that the insurance company has to give a care at all about how well it's working for you. They're allowed to say, nope, there's no published literature that suggests that might be true. We don't care what your own experience is. So that may be one route, is just so to lower the cost, maybe to write a treatment authorization to see if, saying I can't take the generics. The generic should be made the same way as it's been made for the last 15 years. I've had a variety of responses. I've had many people who are switched to generic versions of Vyvanse and weren't even aware of it. I've had a handful of people who felt that their experience was the generic did work differently for them. It is one of the drugs that I would have expected would be less susceptible to differences between the generic and the brand name, because if you are really making Vyvanse, it is the lysine is chemically linked to the dextroamphetamine. Until that bond is broken, which happens in the bloodstream, so absorption should be a smaller factor with Vyvanse than for many other drugs, because it's an inactive drug that's going on. And again, the rate limiting step for availability is what's happening in the bloodstream. So it should be harder for the generic companies to screw up on that. But different individuals have had different effects. So Dennis reports that anecdotally, he once took dexedrine spanchules, so dextroamphetamine, with baking soda, and it felt like I had taken 70 milligrams. So a few people did write into the comments after my talk. So much less, so there's a little bit again of research of antacids lowering pH, and that should theoretically make these drugs more absorbable and may make them less excretable, readily excretable. The quickest form of antacids are simple chemical antacids like baking soda or calcium carbonate, also in Tums. Those effects are usually pretty short-lived, so you'd have to be taking it with the drug, with the base that you're adding to decrease, or not to increase the pH, decrease the acidity of your stomach. And the other antacids we have available, I talked in the last week's talk, histamine 2 blockers like ranitidine, I'm blanking on any of the brand names. Usually their effects are lasting for a few hours, so it might be, and the proton pump inhibitors, things like omeprazole, which I think I'm remembering correctly is Prilosec, those effects can last for up to a day. So they're even separating the timing of your drug use with the antacid, if it's a proton pump inhibitor, is not going to be very effective. You're still, if the acidity of the stomach is affected for hours and hours with those drugs. So Surhat's adding that he's read that quite a few people have reported that they felt that their Vyvanse was different, and that there's even a lawsuit in Sweden right now. I'm not aware of the details of that, so I will try to look into that, because that's clearly, I mean, it is the single most popular, or was before it went generic, single most popular stimulant being used for ADHD. Now, as a class, generic Adderall had a large, slightly large, and Ritalin had slightly larger market shares, but that's a variety of different products. So Slitch reports, if I wait 1 hour after Vyvanse consumption, all the Listex amphetamine will already be absorbed and slowly get converted to dexamphetamine by my liver. So it's actually, no, it's actually your red blood cells have most of the enzyme that does it, not the liver. So food consumption will have no impact on it, right? So that would be the assumption working from basic principles. Again, I've had some individuals who report otherwise, but you would think that Vyvanse would be less susceptible to the absorption factor, because again, the absorption is less I mean, yes, it has to, the list does, this amphetamine has to get into your body, but that's not what's basically determining the level of your drug at any time. It's cleaving that lysine off. KLB Kate says complex PTSD and ADHD are causing bad sleep and beginning depression. The brain fog is strong right now. Will sleep, water, and exercise fix this? I do take the correct daily vitamins and the fog is too strong. So I would try to focus most on sleep, because I mean, all of those are good to get good hydration, to get exercise particularly. But sleep is absolutely crucial to how well the brain is behaving on a daily basis. We know it's intimately tied in with ADHD in both directions. Bad sleep worsens ADHD symptoms. Bad ADHD or severe ADHD makes it harder to maintain any regular schedule. And so 2 other points here with sleep. With sleep, we've known for decades and decades, it's not just the duration of sleep. And yet every public service announcement says, get your 8 hours of sleep, get your 8 hours of sleep. It's absolutely important to get quality sleep. And a big part of the quality is getting it at the same time. So if you're used to sleeping close to midnight to 8 a.m., but you go on a Fortnite or other playing game on the internet for 6 hours and you don't go to bed till 6 a.m., and try to sleep your same 8 hours, but from 6 a.m. to 2 p.m., the quality of that sleep is not as restorative. Your brain is not in the same place, even if you slept solidly for those 8 hours, as it would be if you slept at nighttime. So we shouldn't ignore the circadian factors. Particularly, getting back to the question, if complex PTSD is part of the issue, that's an even stronger case for using techniques like cyclic sighing to help with sleep and help decrease overactivation of the sympathetic nervous system. And yes, it's possible, I mean, that just regulating sleep, good hydration, and getting enough exercise can have, in and of themselves, they can. Whether they will in your case, I don't know. And I don't even know with the individual patients I work with more closely. It's hard to predict the extent of the benefits for a given individual, but without getting good sleep, you're almost certainly not going to be at your best mentally. So does hydroxyzine, an H1 blocker, block dopamine? That I just don't know off the top of my head. I'll launch into a little in the talk, and I don't know how many of you saw it ahead of time or not. So I'll launch into a little bit about histamine because those are important with ADHD. So traditionally, the drugs that we used as anti-allergy medicines were histamine 1 blockers. So histamine 1 is found throughout the body, some in the brain, but a lot in the peripheral body, and they're involved in histamine release, the histamine 1 system, which is what causes your runny nose and your irritated palate, and lots of the symptoms are histamine driven. So among the histamine blockers, the Benadryl, diphenhydramine, and many of the old histamines were sedating because they were working on peripheral histamine 1 blockers and histamine receptors and histamine 1 receptors in the brain. And histamine 1 receptors in the brain, if you block them, you wind up being sedated. The newer is more than 10 years old now, the cetirizine and loratadine, which are Zyrtec, and blanking on the other brand name, Claritin, try to be more specific for the peripheral histamine 1 receptor, less effect on the brain, less sedating. Some people do feel sedated from those drugs, even though there is some specificity, there is still some spillover for some people. So that's the histamine 1 receptor. The histamine 2 receptor, largely in the stomach, and causes the release of acid, which is why histamine 2 drugs are antacids or deacidify the stomach. And to complicate things even more, there's a histamine 3 receptor, and this one gets really confusing. So histamine 3 is an autoreceptor on those histamine cells, largely in the brain. So blocking histamine 3 is actually blocking the effects of histamine release. Am I going to get this backwards? So a histamine 3 blocker, unlike a histamine 1 blocker, which works, that's nonspecific and is sedating, a histamine 3 blocker actually causes awakeness, and there is one histamine 3 blocker that's been FDA approved for narcolepsy. People are falling asleep abruptly and unexpectedly during the daytime, and there has been some research, I don't know how aggressively they're pushing it, looking at that for ADHD, because drugs that keep you awake and alert, and particularly ones that may not tap strongly into an over-arousal sympathetic nervous system, might be desirable. So that's an aside. Hopefully it wasn't too long. So Mr. AKA is he's reporting that he's heard that mixed amphetamines are not legal in Sweden and most of Europe. So one way to figure out if somebody is abusing illicit amphetamines is to test for levoamphetamine in the urine. I don't know on a country-to-country basis. I know that there's also a difference between what's been approved and what's been highly discouraged. So particularly countries like France and Spain, I've had patients living there who felt that even if the drug was legally on the formularies, it's been extremely hard to obtain it, and many people are pushed towards slow-acting Ritalin methylphenidate products. And I'm not remembering the intricate, but so yes, someone, illicit abusive stimulants, certainly urine tests are widely used for them, and I think they are looking at ratios of levo and dextroamphetamine as part of a way of indicating, whether someone's using off-label use of a prescription medication or just using street stimulants there. So Zazushka asks, should we expect new ADHD medications to come out in the next 10 years? I'm tired from the side effects of stimulants and from the stigma associated with taking them. So prediction's always a tricky business until the future arrives. There are certainly active investigations going on. There have been a few non-stimulants like Qelbree, viloxazine, released fairly recently. Sunosi, I'm blanking on its generic name, but I have a talk on that, has been approved for narcolepsy again, and there is very active investigation, and they've already finished stage 3 drug trials for its approval in the US. So there are drugs in the pipeline. I mean, there have been nicotine drugs that were explored in the past. I don't think any of those are being actively investigated. The pharmaceutical company clearly sees that this is a large market and a growing market as we become more aware of adults having ADHD. How much that will help reduce stigma from stimulants, it may or it may not. But I think there's reason to be hopeful that there may be more options out there. And there are certainly options, most of these are not considered first-rate choices, but there are people who certainly get good benefit from Wellbutrin or bupropion, which has never been approved, or even there are a few studies showing it works for ADHD, but no company is investigating getting approval from the FDA for its use in Wellbutrin. And even things like amantadine, which I've talked about in another talk here, or buspirone, for some people or groups of people with ADHD on a whole do seem to show some benefit for ADHD symptoms. I think even more than medications, there's going to be increasing emphasis on non-medication approaches. There was a study earlier this year using EEG. So this is in my amygdala talk, using a special form of neurofeedback, EEG generated specifically addressing amygdala activation, supposedly showing, and this was just a pilot study, showing some benefit for ADHD. So I do have a talk on neurofeedback, and my oversimplification is that given how long it's been around, given how many people have been on it, given how much money they are paying for each session, the neurofeedback community has been hugely remiss in being able to publish studies that clearly show efficacy for ADHD. I'm not saying it's ineffective. I'm just saying the studies to date are woefully inadequate, but hopefully that will be changing if there really is some benefit there. So Sirhat reports that anytime when he tells people an ADHD medication isn't working, people say tolerance, but his experience, I'm thinking it's he, I can't see the picture very well, it's tiny on but say tolerance, but it changes on a month-to-month basis, and how this, and he's saying it's not due to any changes in diet or exercise. Any ideas why? So I usually begin with that most people with ADHD notice pretty significant day-to-day differences in the degree or severity of their ADHD symptoms, with number one contributor on that list is how well they slept or not, and exercise can certainly play another role. But I've worked with a number of people who have gotten their sleep systems down pretty regularly, might have a regular exercise routine, and there are clearly unidentified factors that do lead to daily severity of ADHD. So if you were taking the same exact medication that even worked to the same extent each day, you would be getting differential effects from your medication. Sirhat's question, though, looks more like it's a month-to-month basis. I'll touch the tolerance. I do have a talk, excuse me, on tolerance in ADHD medications. And there my summary is, widely different assessments. If you talk to the ADHD experts, most of them will say people need some few weeks, a few months to sort out what. I don't even have water by the desk, so I may need to quickly get some. So most of the ADHD experts say might take a few weeks or a few months to sort out what dose works, but usually once a dose is working, it continues to work. We don't see much tolerance. If you talk to the if you talk to the substance abuse experts, who are more often dealing with cocaine and methamphetamine, they will say stimulants, everyone gets tolerant to them very quickly. Everyone's going to get tolerant to prescription stimulants. What I saw in my own practice when I crunched the numbers, and I crunched 100 patients, the first 100, this was during COVID, and my requirement was they already had to be on a stable dose for a year, and then just taking a year in time and seeing if they were on the same dose a year later. And what I predicted was almost exactly what I saw, which means I have a good mental tracking of my patients, but about 80% were on the same dose. So most of them were not growing tolerant. And of those who needed a dosage change, about half went up and about half went down. This was during COVID when anxiety levels were high. And I think that's why there were almost as many needing to go down on the dose as needing to go up on the dose. I think in more, not that our world will ever be anxiety free, but I think in more usual times, I'd probably see more people who did have some tolerance or did need to go up than did need to go down. But if it's happening on a month-to-month basis, to me, that seems correlated with the batch of medications. We know particularly Concerta, and I'll give a shout out to Gina Pera, her blog, I think it's called the ADHD Roller Coaster, or something like that. Her last name is Pera. She has a background in investigative journalism, so she has done much more detailed work on the problems with non-bioequivalent forms of Concerta and how the FDA in the US dragged its feet about agreeing to whether, yes, we approve these forms, but they're not really having the same effect in people's bodies. So getting back to Sirhat, I mean, it's certainly conceivable. Many people with a variety, and it's not just ADHD medications, certainly see it with benzodiazepines. If you go on Reddit or online, people will say, Mallinckrodt, and I don't know which brands off the top of my head, Mallinckrodt worked this well, and this other brand works, Sanofi's works so much worse. So at least in the US, when you have a generic drug, the manufacturer of that generic drug is printed on the label of the bottle. It may be in even tinier print than the rest of the tiny print, but you can figure out what you are taking. And if it disagrees with you, you can ask your doctor. They have to be willing to do it, to specify, do not fill with Mallinckrodt, do not fill with Teva brand, or conversely, if that's one of the brands that worked for you, you can ask to request that. However, that may mean you have to wait longer for the pharmacy to fill it for you, because the pharmacies tend to go with who's ever cheap each month. I know with Vyvanse, within a month of it going generic, there were at least a dozen different manufacturers making it, which means, again, they're supposed to be making the same product. There is some slop, sort of 15% give or take, in terms of both how quickly it goes in or the timing of the peak. The timing of the peak and the area under the curve are the only two variables the FDA routinely requires checking for. There's certainly could be other variabilities in how they're delivered, which aren't even being measured. And 15% slop is a moderately high amount of slop allowed. So that's my thought, is to see if you can correlate any change in your response to the exact manufacturer of the drug you're taking. So transcription said that they watched my neuroinflammation video and found a journal review article on Montelukast. So that's an anti-inflammatory medication. I'm blanking on its generic name, or maybe that is a generic name and it's more so he or she has experimented with 4 times 40 milligrams having an inflammatory role, but he does feel more awake and clear-headed when doing that. So suggesting that neuroinflammation processes. There are also just some studies this week showing strong correlations with post-COVID infections and neuroinflammation. And there's one other condition, neurologic condition, where more and more evidence is implicating neuroinflammation as having a major role in direct, immediate, online brain functioning. So Mr. AKA asked, how many Aloha shirts do I own? My birthday was this past weekend, so I just got one. I'll share my bad joke. If I knew how to show pictures, I'd show a picture. It was a cool, the Honolulu Museum of Art has a special exhibition on Aloha shirts going on right now. So 2 rooms on the history and showing Aloha shirts. They had Aloha shirts for sale, and I got a pink and purple one with eels on it. But I joke that it's my Italian love shirt. I won't sing, but because that's amore. It's more eels all over the shirt. Anyway, so enough distraction there. So maybe 5 shirts, maybe 4 shirts. So Montelukast, yep. Does so Sniper Channel, hello, welcome back. Does hyperthyroidism make antidepressants less efficient? My simple answer, without knowing enough in detail, is probably. So I think, though, the biggest answer is that hypothyroidism itself can mimic lots of effects of depression. And at a biological level, you're probably pushing against more. So that's a little different than whether it makes it less efficient. It's making it a bigger task. But the thyroid is involved. I mean, we think of it largely in temperature regulation and a few other things, but it's modifying genetic transcription of more than 100 different genes in the body. And almost certainly some of those are involved in how antidepressants are working in our process. The other thing is if your whole digestive system is working more slowly, I mean, that could mean increased transit time, may mean that more actually of a drug gets absorbed. So there are potentially a multitude of factors from something as simplistic as thyroid gland. So Sniper Channel asks, is Strattera dose dependent? So I would say absolutely, in terms of both side effects and benefits. It is dose dependent. And I think, so one of my pet peeves, and some of you have heard me talk about it before, is that for years there's been this myth promulgated: stimulants are wonderful for ADHD, and part of why they're wonderful is they work immediately. They're changing norepinephrine and dopamine levels immediately or within minutes. And that our non-stimulants, which many of them are modified antidepressants or look like antidepressants, take weeks to work because antidepressants work indirectly. But I think a lot of it is confusion here with Strattera. So Strattera does have direct, immediate norepinephrine reuptake action within minutes, just like Ritalin does. On that basis, you would expect, at a neuroscientific basis, that it would have some immediate effects. But so many people have side effects and reactions with Strattera, we tend to taper up. We tend to start at doses that are below the therapeutic dose and take weeks to taper up. Now, there is additional evidence that even once you're at a therapeutic level, there may be benefits to Strattera for ADHD that accrue over the following weeks. So I'm not saying all of its effects are immediate, but some of them are, and certainly with Wellbutrin they are, and certainly with duloxetine Cymbalta they are. So I think many of the leaders in the field sort of confuse the fact that we need to taper Strattera slowly before you get to a therapeutic effect with the claim that therefore non-stimulants take a long time to work. Just not true on a basic science or an experiential level with my patients. So transcription, I think, is trying to get back to Serhat's question about month-to-month variation. And it's pointing out that there's seasonal patterns. There are seasonal patterns to dopamine that transcriptions bring up. There's certainly seasonal patterns to serotonin synthesis and availability. There also could be temperature factors that may be playing a role. So again, though, if I guess I would differentiate seasonal patterns versus month to month, particularly if it's flipping back within the same season. We would not expect those to have weather patterns, temperature patterns to be the source of his issues. So hello, Amadi. Again, do anti-anxiety drugs help in ADHD, and what can I do to avoid dependence on them? And thank you for the happy birthday wishes. So one is I would lump anxiety drugs into two big classes, and I do have 15 more minutes I can talk, and fortunately didn't need any water. So perhaps the most commonly used anti-anxiety drugs are the benzodiazepines, so the Valium-like drugs. I'll give the brand names. So in America, that's Valium, Xanax, Ativan, Klonopin, Librium. Some of these are used only for sleep, like Halcyon, which still works on. So those are directly sedating. In many cases, they are sort of working directly in opposition to, they are downers, while most of the ADHD medications are uppers or activating the sympathetic nervous system. These are dampening down. So to that extent, they are combating with it. Many people use them, the timing of them, particularly a short-acting benzodiazepine in the evening to get to sleep and shut things down. That's not considered particularly good practice. I've had a few patients over the years who came in to me on such a regimen and resisted many attempts to alter them from it. With the benzodiazepines, almost everyone does develop tolerance with time, so dosages tend to go up. So one option to avoid that whole picture is there are other anti-anxiety drugs, particularly drugs with serotonin reuptake action. So the SSRIs, the SNRIs, serotonin and norepinephrine reuptake inhibitors, and some drugs that are serotonin 1A agents like buspirone. The downside is all of those work slowly and gradually for anxiety, so usually days to weeks. The good thing is that they tend not to be directly sedating, so they're less in opposition, and particularly duloxetine Cymbalta and or milnacipran, which is Savella and Fatsima. The norepinephrine action may actually help with ADHD as well as the combined serotonin and norepinephrine helping with anxiety. So that is usually a better route to go. There's also people who essentially, and guanfacine, initially a blood pressure medicine, FDA approved for ADHD, but some people do use it off-label just for help with anxiety. Again, it tends to work slowly. It can be sedating, so it's usually taken at nighttime. So those are things I would suggest. So Sniper was, I guess, asking about hyperthyroid versus hypothyroid. I mean, interesting. I mean, the shorthand is hyperthyroid tends to rev people up, speed metabolism, make people hotter, more irritable. Their hair falls out, they lose weight. Both hypo and hyperthyroidism are associated with depression. So given that the body is in a more revved up state, could it be chewing through drugs more rapidly? That's possible, but I don't know specifically about the P450 enzymes and ones that are likely to interfere with antidepressants and how much the thyroid might be affecting that. So transcriptions, adding a little more information about montelukast, which is a leukotriene inhibitor. Has some antiviral action, and it's being studied in influenza as well as COVID, and it's being studied for long COVID. So Ahmad says he was on Strattera for 6 months, but is now on methylphenidate, and it's much better than Strattera. So he's been able to quit smoking. Great. And great, I'd say potentially unfortunate, not unfortunate. Stopping smoking, always a good thing. What's important to acknowledge, and I do have a talk, I think, on nicotine and smoking, is that nicotine does seem to have some direct benefits for ADHD. There are nicotine agents that were being investigated by drug companies. I don't think any of them are currently being pushed forward. So even though it's great for your lungs, your heart, your eyes, your penis, your everything in your body with blood vessels, essentially, stopping smoking is good. There are some people who lose some ADHD benefit when they're not smoking, and that so you might need a slightly higher dose of methylphenidate. The other interesting thing about nicotine is it's one of the few drugs that can both increase focus and attention while decreasing anxiety, sort of getting back to Ahmad's question, which is, I mean, it's not just social customs and cultural expectations. Those are part of it. Why taking a cigarette break is relaxing. There do seem to be direct physiologic effects that can be both brain sharpening but relaxing from nicotine. So more appreciation for whatever sense of humor I have, and more birthday wishes. Thank you. I appreciate it. And Sniper shares some more that no antidepressant worked except venlafaxine, and he had, which is Effexor, generic. And he had hypothyroidism at the TSH was 7. So TSH is high. It's trying to send a signal, make more thyroid hormone, make more thyroid hormone. You don't mention whether duloxetine. I usually prefer duloxetine to Effexor in most situations just because it's more robust norepinephrine action and less quick departure from receptors. So Effexor tends to be with Paxil tied, maybe is among the antidepressants with the worst record for antidepressant withdrawal. So feeling really lousy from missing a dose or stopping it abruptly. And I do have a talk on antidepressant withdrawal on this channel. So Ahmadi does sort of support what I was saying about nicotine, that he does miss its calming effects. So I do have talks both on atomoxetine, Strattera, and I don't know where I address the duloxetine. So they're almost equally potent, again, dosage and absorption and other factors. They're almost equally potent as norepinephrine reuptake inhibitors, duloxetine and atomoxetine. And what I'm saying now is completely my conjecture, but Eli Lilly made both drugs. When they came out with Strattera atomoxetine, they had the market cornered for several years as the only FDA-approved non-stimulant for ADHD. They had no desire to step on that market, confuse consumers or anything else. So when they developed duloxetine as a antidepressant, anti-anxiety, and helpful for certain forms of chronic pain like diabetic neuropathy, that was enough going on with duloxetine Cymbalta. They certainly had no interest in promoting it for ADHD, although, again, there are a few studies, and it seems to be they're not head-to-head, so different dosing, different protocols, different patient populations may play a role. I'd say the evidence is pretty strong that it's as effective as atomoxetine for ADHD, and that it's far more better tolerated in what I've seen over a decade and a half of both drugs being around. So Heidi asks, can Buspar help ADHD as well? So yeah, again, there's some evidence that it can. I'm pretty sure I have a talk on that in this channel. Heidi's taking 70 milligrams generic Vyvanse every morning, but the effect doesn't last long. So with Vyvanse, I mean, going higher than 70, and I know that some insurance companies won't let you do it, but the biggest effect it will have will be to increase the duration of the effect rather than boosting the intensity of it. And that's because the red blood cells, which are the rate controlling step, are limited. They just can't churn out any amphetamine, dextroamphetamine faster. At a certain level, they get saturated. But that means delivering more Vyvanse, the prodrug, dexamphetamine, should result in a longer duration of effect because you are increasing the time that the active product is being produced over. So Maxima asks, why does Ritalin work instantly but bupropion not? So to be clear, so that is the same claim that the ADHD experts have made for years, and I think they're flat out wrong. I can give you testimonials from more than 24 individuals with ADHD without depression who had immediate, the day they started taking it, they could see the benefits of bupropion for their ADHD. If they changed the dose, if they skipped the dose, it had immediate effects. So two things. Any given drug can have multiple effects in the brain and body. So bupropion's having immediate dopamine and norepinephrine reuptake effects that has immediate benefit for ADHD, but it's also having indirect effects. We don't know in detail what they all are, or we'd probably have more effective antidepressant agents on the market. Some of it almost certainly is involved in making new proteins. Some of it may be involved with making new brain cells in the hippocampus and other areas. These are slow processes that take a long time to gear up. So bupropion, side effects can show up right away. So if someone's going to feel agitated, that often shows up right away. Energy effects, probably direct dopamine and or particularly norepinephrine effects, those can show up right away. But mood effects do tend to be gradual with bupropion. But a drug is certainly allowed to have effects at two different time courses from, it is one substance, but it's having a multitude of effects, some of which are immediate and direct, and some of which are slow and indirect. So Sniper Channel reports that with the weight of 85, and I'm assuming that's kilograms, is taking 80 milligrams of atomoxetine. That's, a fairly typical dose, but if effects are less than desirable and you've been on that dose for a while, and I am not making any specific medical recommendations, I would say, many people find it reasonable to experiment with the dose. If you're having great effects, then no need to monkey with it. So I focus much less on the numbers than on the biological effect. If you're having side effects and no benefits, that's too much. If you're having tolerable side effects and benefits, okay, and maybe even worth trying a higher dose. If you're having just benefits and no side effects, great. But in terms of sufficiency of dosage, we're treating people, we're not treating numbers, unless you're the insurance industry. And increasingly doctors that are subservient to the insurance industry, as all of us are to some extent, greater or lesser. So transcription is sharing. He found a study on helminths, which is a kind of fluke, a little worm, study from the 1950s where nicotine undid the effects of amphetamine on the flukes. So he proclaims, or they proclaim they are the worm. So I have about 2 minutes left. Maximus is saying bupropion is surely better for patients with comorbid depression. So, and wonders whether Ritalin is helpful for dealing with depression states. So there's research going back to the 50s and 60s, not on worms, these are on real people. The addiction potential, the potential for problems was, so depression tends to be a chronic condition. ADHD in that area wasn't even being considered as an option in adults. But there are studies, almost all of them were on patients who were hospitalized for depression and were in an inpatient setting, either because they were hospitalized or they had some other illness like cancer. And it was only in that situation where it was deemed safe enough to treat people with methylphenidate for depression. But it works there and it works quickly for depression. So we have lots of studies that Ritalin does have antidepressant effect, and it's probably tied into some of its euphoric effects that are happening very quickly. And I've certainly, it is, it's on the list of things for treatment-resistant depression to consider, but almost always it's sort of swept away in a back corner, or don't use this, don't advertise the fact that we're using this. It also makes research kind of tricky because so many modern studies look at different aspects of ADHD as a measure of who has ADHD. Sometimes they're just looking at who's been prescribed a stimulant. Stimulants are prescribed for uses other than ADHD, with depression being probably one of the most common other ones. It's also being used for ADHD-like conditions like CFIDs and chronic COVID and long COVID and head trauma. So Wesley DeVries is asking, could he take orange juice after he's already consumed his stimulant to hasten excretion? So theoretically, that's possible. I don't know, how much orange juice or vitamin C you'd have to take to have it an effect, but certainly, again, separately of absorption and getting in, it should have some impact on clearing it from the blood into the urine. Whether that's going to be a major effect or a minor effect or a detectable effect, I'd say it's worth experimenting, but my clinical experiences, some patients seem to be able to detect such effects and many don't. So So Heidi is asking, what can be the reason that medication doesn't last long? Yeah, so it's a whole nother top. So with pH and acidity, we're focusing pH can affect how well enzymes work. But so Wesley, and I'm going to wrap it up because I need to go. So drug levels, probably most of the drug level in your body is more dependent on how it's metabolized, how it's chewed up by enzymes, than it is by the absorption, how much got in, or how quickly it's being excreted, peed out. And there are substances, grape juice is one of them, that is both acidifying but also impairs, and I think it's the 3A4 primarily isoenzyme of P450, which is involved in degrading a number of psychiatric medications. So again, not that acid base can't be important, but it's playing more of a role in absorption and excretion than in actual drug levels, which are more tied in with metabolism and how quickly primarily your liver is chewing up these different drugs. So thank you all for coming. Thanks for the great questions. I appreciate the birthday wishes. I will be back next week, Tuesday, for live at this time, and I will have a video out on Saturday morning. Double check what this week's topic is. Yeah, I can't read. I know I'm going to be talking about Abilify this month. I know I'm going to be talking, I think, about sluggish cognitive tempo. I'm not sure if it's one of those two or a third one, but I'll post it, and thanks for being here. Have a healthy, happy week. And I'm not getting the button to shut things off. My screen's frozen, so I'm trying to leave. I'm just going to have to shut down Chrome. That's all. Chrome's not shutting down. My whole computer's locked up, and I have a patient to get to. Well, I'm going to reboot everything. That's all. Sorry.